So good morning everyone, I am Dr. Naveen Porwal, your physiology educator at Unacademy. You can join my telegram group, it is given here, and also telegram group of Unacademy. The link is given over here, and this is the batch course which I have just finished on the hematology. And this is the code Dr. Naveen 10 if you want to get 10% discount for Unacademy subscription. And these are the upcoming free classes on NEET PG 2021. So from morning till night, there are so many free classes. You can download the app and you can avail for that. And if you want to join, you can put the code Dr. Naveen 10 to get 10% discount. So these are free classes on NEET PG, and this is the process how to subscribe for plus. Okay, 1 month, 3 month, everything is given over here. And these are the YouTube rituals which we follow from evening to night. This is the foundation batch course. After that, we have finished these classes, these questions. Now coming to the next question, let me open that. So all these things has been done, isn't it? Good morning Akshay, good morning Sadhana. These has been finished, isn't it? Okay. After finishing these questions, let me start with the, just a minute. Okay. When the heart rate is 70 beat per minute, cardiac cycle duration is. These are very simple question, but sometimes we are having fallacy of thought that we know that and we make mistakes. So for practice, these questions are very important. Although these are from repeated, they are from JIPMER, recall based question. And see, there are AIMS, JIPMER, PGI. These are the institutes which are forming the question. They are preparing MCQ and they are very tricky. So if you practice these JIPMER, AIMS and PGI, I don't think that any topic will be left. Yes, Namaste, Bhargo. So what is your answer? When the heart rate is 70 beat per minute, cardiac cycle duration is. Yes, please, you can answer in the comment box. Very, very, very simple question, just common sense. Even if you don't want to calculate, then too you can answer. Yes, Akshay Gupta, you are correct. So duration is of course equal to what? 1 upon heart rate. It is 70 per minute. So it will go up, it becomes 60. So normally it is around 0.850. Okay. So it become 850 millisecond. Yes, absolutely correct. So this was a very easy question. Now coming to the next numerical of physiology. Nowadays they are asking a lot of numerical, and those are very simple numerical. So don't get confused that they are asking numerical, so I should not do. Using fixed principle. Okay, calculate the cardiac output from the following data. So they want you, yes, good morning or Rav Verma. They want you to calculate cardiac output by fixed principle. So you should know only the fixed principle. What is fixed principle? And these values are given over here, and by this you have to calculate cardiac output. So who will tell me what is formula for fixed principle? What is the formula? Yes, Sumant Gupta, absolutely correct. Please tell me formula for that. What is formula for fixed principle? Yes, good morning Venu Shankar, good morning all. Please join fast, everyone. What is the formula? Anyone? Fixed principle, I'm asking about fixed principle. It will be oxygen consumption. So here it is 250 ml per minute, isn't it? 250 ml per minute upon arterial oxygen content minus venous oxygen content. Yes, Sumant Gupta, you are absolutely correct. Absolutely correct. So this become approximately 250 upon 5. And if you change the value, it comes around 5. So 5 liter is the appropriate answer. So for these simple question, you need to remember formula of fixed principle. It is your oxygen consumption. It is your oxygen consumption upon arterial oxygen consumption minus venous. Okay, so this is a very simple formula and simple question. Next question. Now this is very important question. All of the following are true of baroreceptors except. See, every year one question is definitely from baroreceptor. It can be high pressure, low pressure, yes, stretch receptor, or it is made less sensitive by volatile agents. It reset firing level in the chronic hypertension, or carotid sinus innervation is by vagus nerve. What is your answer? Made less volatile, made less sensitive by volatile agent. Okay. What about others? Yes, I. B. Good morning, Aditi. Good morning. Yes, what is your answer? So everyone is answering B. Okay, let me explain this topic. Okay, someone has given D, C. So everyone has a different answer. This is a good question. So let me tell you, answer is, of course, before telling you answer, let me discuss how many types of baroreceptor do you know? Answer is D. Answer is D. I will discuss that. Baroreceptors are of how many types? Before jumping to the conclusion, let me discuss this. Baroreceptors are of two types. One is high pressure. Yes, high pressure baroreceptor, and what? Volume sensing or low pressure. Volume sensing baroreceptor. They are volume sensing baroreceptor, or they are also called as low pressure. High pressure baroreceptors are of again two types. What are those? These are carotid sinus. One is carotid sinus, not body. Not body. Body is chemo. Body is chemoreceptor. Good morning, Horus. And other is aortic sinus. Other is aortic sinus. Okay. Now, what is afferent of carotid sinus? What is afferent of aortic sinus? Who will tell me the afferent? What is afferent of carotid sinus and what is afferent of aortic sinus? Who is going to tell me the afferent? It is ninth nerve, okay, and this is 10th nerve. Yes, now you can go to the question also. See, carotid sinus is by vagus nerve. Yes or no? It is by which nerve? It is by ninth nerve, not vagus nerve. Of course, they are stretch receptor. I will discuss that. Now, these are stretch receptors. See, these carotid and aortic sinus are stretch receptor, as you all know. These all are stretch receptor. Okay. So, if there is, suppose that there is increased blood supply or increased blood flow, it will cause more stretch over here. It will cause more stretch on the, because these are stretch receptor. It is correct option. It is stretch receptor. And if there is increased blood flow, it will give signal from ninth nerve by carotid and 10th nerve by aortic to nucleus tractus solitarius. Now it will supply to two center. What are those two center? One is vasomotor center, other is cardio inhibitory center. Now your BP is increased, so you need to decrease your BP. For that you have to inhibit. You have to inhibit vasomotor center and you have to excite cardio inhibitory center. So this will decrease your heart rate and this will increase your BP. Now one thing you need to understand, the person who are having chronic hypertension, okay, so there is resetting. For example, for your hunger center, for satiety, every center can be reset. So someone who is having chronic hypertension, their values can be reset. Okay, suppose that your values are reset at this, and if you are having chronic elevated blood pressure. So the reset will be 140 by 90. So body will try to become this normal. So this will be new normal. This will be new normal for the patient who is having chronic hypertension. So this is a correct statement. It is not wrong. Many of you are asking that it can be reset if person is having chronic hypertension. So this statement is, where is that? Reset firing level. So body is trying to achieve the new normal. It can be 140, it can be 160. So body want to achieve the new normal, and it can be 140 or 150, whatever be the new normal. So chronic hypertension can have reset firing level, and of course they are stretched, and they have observed that they become less sensitive if you bath them or if you treat them with volatile agent. So these are observational finding. This is the factual finding, this is the clinical finding, and this is the physiological finding. That ninth nerve is for, yes, carotid sinus, and 10th nerve is for aortic. So this is absolutely wrong. So answer is D. I hope this is correct. And again, you should know also about volume sensing baroreceptor. Which type of reflex is activated by these receptor? Which type of reflexes are activated by volume sensing baroreceptor? They are present in mainly right atrium. They are present mainly in, yes, very good, Akshay Gupta. Excellent. It is Bainbridge reflex. And what is the response of Bainbridge? What is the response of Bainbridge reflex? Yes, very good. Main response is increase heart rate, then decrease ADH, and increase atrial natriuretic polypeptide. So these are response of Bainbridge reflex, and these are low pressure baroreceptor or volume sensing baroreceptor in comparison to what? High pressure baroreceptor. So they are for high volumic state or low volumic state. They are responsible for high volumic state or low volumic state. Yes, they will be activated in hypervolemia. Of course, they will be activated in hypervolemia when there is more amount of fluid. When there is more amount of fluid, volume sensor baroreceptor will be activated, and simply there is more volume of fluid, they will try to contract, they will try to tachycardia, so that fluid can be excreted via your kidney, isn't it? So this is about a brief discussion of your baroreceptor. So this point is very important. Please note down this in your notebook, along with all the point that it can be reset the firing level when there is chronic hypertension. Okay. Now next question. If pressures in the capillary and interstitial space. Now see, every year one question is definitely from these stalling forces. These questions are very simple, very easy, but you have to make your brain, very clear, because these are very simple questions. Suppose that this is your capillary, and this is your interstitium. So if the pressure in the capillary and interstitium space at the top of lung are 3 and 0, suppose that hydrostatic pressure here is 3 and in the interstitium it is 0 respectively, and the collide osmotic pressure of the blood and interstitial are 25. Now question letter was too small. Okay, let me zoom this. Can you see it now? Yes, Ranjit, can you see now? So oncotic pressure of the blood is, okay, it is how much? 25, and oncotic pressure in the interstitium is only 5. Now what will be the direction and what is the net filtration pressure? Who will answer me? So this is approximately how much? 3, and this is approximately 20. So what is your answer? No, this is 3, and this is 20. So what is your answer? 23. No. 20 minus 3, 20 is going inside and 3 is going outside, so it is 17. Yes, answer is 17. So fluid is moving in the capillary or out the capillary? Fluid is filtered or moving in the capillary? Yes, tell me. Fluid is filtering or moving inside the capillary? Filtered? No. This is filtration or this is moving inside? If you see, the net result is this can be also in the option. Okay, it is not filtered, it is moving inside. You can see the filtration value is only 3 and the fluid is moving inside by 20. Oncotic pressure means the water can be retained and hydrostatic pressure means water can be moved. If water is moving out, it is because of hydrostatic pressure. If water is retained, it is because of oncotic pressure. Yesterday also we have discussed this. So fluid is moving inside. So the net filtration pressure will be 17, and that too inside the capillary. Inside your capillary. So these are very simple. You should make a mental makeup in your examination. This is the capillary, this is the fluid, and this is moving inside or outside. So that can also be in the option. Now this is also a very beautiful question. Which is false? Which is false about funny channel in the heart? Which is false about funny channels in the heart? It is a sodium potassium channel. It is responsible for spontaneous rhythm producing tissue of heart. They are voltage dependent channel only, or they are responsible for diastolic depolarization, which is not correct. Which option is not correct? Which is incorrect option? Everyone answer me, then I will discuss that point. A, it is sodium potassium channel. C, it is voltage dependent channel. Okay. A. These are beautifully designed question by Jipmer. They are recall based question, and you need to practice a lot in these questions. So answers are varying. So let me discuss the point. Please everyone answer whatever you think. Let me see how many are answering what. Even if you are wrong, there is no problem because we are learning. We are in the learning phase. You should answer. Okay. So let me tell you answer first, then I will discuss. Answer is C. Answer is C. They are voltage dependent channel only. No. They are voltage gated as well as ligand gated. They are voltage gated as well as ligand gated, both. Not only, they are not only. Of course, they are voltage dependent channel, but also ligand gated. Now let me discuss this. As you know, this is your pacemaker potential. There are three names for this. One is pacemaker potential. One is pacemaker potential. Other is pre-potential. And third is the name which was asked in the question. It is also called as diastolic potential. There are three names for the same thing. And we should know this is called as which phase? This is called as 4. This is called as 0. And this is called as 3. This is called as 4, 0, 3. You should remember this also, because sometime in examination they will ask you what happened in phase 0, what happened in phase 4, and it can be compared by this diagram of the cardiac. This is 0, this is 1, 2, 3, 4. So 0 is depolarization, 3 is repolarization, and 4th is normally maintenance of RMP, but here it is pacemaker potential. So you can compare this by normal action potential of atrium and ventricle. Okay, so this is about pacemaker potential. Now, as you know already, this is because of three types of things. Number one, there is influx of which ion? Which type of sodium ion? Each point is MCQ. There is influx of which type of sodium ion? Slow sodium or fast sodium? So you need to remember that it is slow sodium, number one. Number two, there is influx of, yes Akshay, you are correct. Very good. There is influx of T calcium. Yes, or else T means transient. They are transient, not long lasting. And there is decrease exit of potassium. Decrease exit of potassium. So these are sodium potassium channel, but these are not sodium potassium pump. So don't get confused with the sodium potassium pump. They are sodium potassium channel by which sodium is coming inside and potassium is going slowly outside. So why they are called as funny? Because the scientist who has seen this, that after repolarization, sodium is coming inside. Okay, so he said that this is the funny thing, that there is depolarization, there is repolarization, and just after repolarization there should be RMP. But in assay node, sodium is coming inside, slow sodium are coming inside. So he named them as funny leaky channel. He named them as funny leaky channel which open at a certain voltage. So they are also called as voltage gated channel. So these, they saw that after normally depolarization is there, repolarization is there, then there is RMP. Then again stimulus is there which will cause depolarization and repolarization. But without stimulus, they are automatic. Without stimulus, they are going to produce action potential, and that because of funny channel, that because of slow sodium channel, that because of T calcium channel. So these are sodium potassium channel, not pump, by which sodium is coming inside and outflux is very slow. Okay, now point number two, I told you they are not only voltage but they are also ligand gated. So which ligand they are obeying? It is cyclic AMP. Let me discuss that also. As you know already that in your heart there are two receptors. One is beta 1, other is muscarinic 2. Beta 1 and muscarinic 2, these are GPCR. This is GS and this is GI. This is GS and this is your GI. Now this is activated when there is sympathetic stimulation. This is activated when there is sympathetic stimulation, and this is activated when there is parasympathetic stimulation. When there is parasympathetic stimulation, for example, this is your SA node, this is your GS 1, 2, 3, 4, 5, 6, 7. Okay, and this is your GI 1, 2, 3, 4, 5, 6, 7. Okay, and this is your adenyl cyclase. This is adenyl cyclase. So when you are sympathetically stimulated, beta 1 will be activated. Beta 1 will be activated. For example, there is adrenaline and beta 1 is activated, and this will increase your cyclic AMP. And when you are relaxed, acetylcholine is released. When you are relaxed, acetylcholine is released, and this will decrease your cyclic AMP. So cyclic AMP is a ligand. It is a ligand. For example, this is your action potential. And if cyclic AMP is activated, it will phosphorylate the sodium channel. It will phosphorylate the calcium channel, and that is why it is also called as cyclic AMP dependent channel. So they are not only voltage gated, as you know, whenever there is fluctuation in the voltage, there is depolarization, there is repolarization, and when there is change in the voltage, they can be activated. But cyclic AMP can be also acting like a ligand, and these can open your channel. So coming back to the question, coming back to your question, it is a sodium potassium channel. Absolutely correct. Is it a sodium potassium channel? Absolutely correct. It is responsible for spontaneous rhythm producing tissue of the heart. Absolutely correct, because it is automatic. It is responsible for your automaticity. They are voltage dependent channel only? No, they are voltage dependent channel as well as ligand gated channel by cyclic AMP, and they are responsible for diastolic potential. Yes, pre-potential, pacemaker potential, and diastolic potential, they are name of the same thing, and they are also called as H. Yes, Akshay, you are correct. They are also called as HCN channel. What is HCN channel? HCN channel means hyperpolarization induced. Hyperpolarization induced cyclic AMP dependent channel. So you can see that this portion is showing that it is voltage gated, and this portion is showing that it is ligand gated. So it is both voltage gated as well as ligand gated. So this point, a new point, it is asked in Japan for the first time. So this can be repeated in your aims as well as NEET PG. So please remember this point very carefully. Okay. Which of the following best describe NREP effect? What is NREP effect? Increase preload, decrease cardiac contractility. Increase afterload, increase cardiac contractility. Increase preload, decrease cardiac relaxation, or decrease afterload, decrease cardiac relaxation. What is your correct answer? Tell me your answer, then I will explain. It is a factual point. You should know what is NREP effect in your heart. What is NREP effect in your heart basically? If you practice JIPMER question, AIMS question, and PGI question of all the subject, I don't think any question will be left. Instead of going about all those fudgy type of question, try to practice JIPMER, PGI, and AIMS. Yes, Sai, yes. C, increase preload, decrease cardiac relation. Okay, let me answer. I will discuss that after answering everyone. So please, everyone should answer. Don't hesitate in answering the question. Increase afterload, increase cardiac contractility. Okay. Increase afterload, increase cardiac contractility. Okay. What about others? There are. Okay, answer. Let me, without wasting time, let me tell you. Increase afterload increases cardiac contractility. Now, who will explain this physiology? Who will explain why it is correct? Why this point is correct? Increase afterload is going to increase cardiac contractility. This is the correct answer. But who is going to explain this? Before telling about afterload, tell me what is preload and what is afterload in case of heart. What is preload? Sting law, okay? What is preload and what is afterload? Preload is basically end diastolic volume. It is end diastolic volume, or the volume of blood present before contraction or after relaxation, after diastole. Yes, end diastolic volume. Very good. Preload is end diastolic volume. And what is afterload? What is afterload? Total peripheral resistance. Yes, it is mean arterial pressure. Very good. It is mean arterial pressure. It is pressure in your aorta. It is pressure in your aorta. Suppose that there is a door. There is a door. Suppose that there is a door. The pressure by which you are trying to open that door. Suppose there is a door and you want to open that door. Suppose that the pressure by which you are going to open the door, what is that called as? Preload or afterload? There is a door and you want to open that door. The pressure which you are applying, to open that door is preload or afterload? It is preload, isn't it? And the pressure, suppose some afterload. No, it is preload. The pressure by which you are opening the door, not you are inhibiting the door. It is not afterload, it is preload. Are you getting me or not? And suppose some other person is standing on the other side and want to prevent the opening of the door. So that is afterload. Yes or no? Suppose you are inside a room and you want to open the door of the room. So that is the pressure what you are applying is preload. And some other person, okay, he is pushing the door. So that is afterload. Similarly, this is your beautiful heart, although it is not beautiful in my diagram. Okay, the pressure, this is the pressure, this is the blood. It is end diastolic volume. So end diastolic volume is the amount of blood present in the heart and want to open which valve? Aortic valve. So this is behaving like preload. Because it want to open when ventricle is contracting, the more is the amount of blood, more will be the force of contraction. More will be the amount of blood, more will be force of contraction. And this you know as a name of Frank-Starling law. This you know by the name of This you understand by the name of Frank-Starling law. And the amount of blood which is present over here, and this is the wall. So this is the wall and this is the amount of blood which is present. So this will prevent or it will facilitate. What do you think? This will prevent opening of aortic valve or this will facilitate? It will prevent opening of aortic valve. So this is called as mean arterial pressure, and you might be knowing about the formula diastolic plus 1/3 of systole minus diastole. This is also called as pulse. Pulse pressure. Okay, now suppose that there is more afterload. So in your ventricle there will be more blood or less blood. If there is more afterload, more blood is not going in the aorta from the ventricle. So the blood which will be left in the ventricle will become more or less. What do you think? If ventricle is trying to pump, and there is a lot of afterload that it cannot be passed out, so amount of blood in the ventricle will be more or less? More. So if amount of blood in the ventricle become more, preload will become more or less? Preload will become more. So force of contraction will also become more. So for time being, it is not for every time. For time being, when there is initial rise in the afterload, it will increase amount of preload. It will increase the contractility because there is a stretch, and that stretch will increase contractility. There is release of calcium and force of contraction will increase. So that is called as NREP effect. Are you getting me or not? That increase afterload can also increase cardiac contractility due to a lot of stretch. Is going on, and that can increase your contractility. So this is called as NREP. So please remember, You know about inotropic action, you know bathmotropic, you know, dromotropic, then lucitropic. You should also add two more effects. One is NREP effect, other I'm going to discuss in the next question. So one is NREP. There is increase after load increases cardiac contractility. Okay. Now next question is Bowditch effect. These two questions were asked in German in the same year. So if you know, you know. If you don't know, see, true about Bowditch effect of the heart. What is true about Bowditch effect of heart? Increase in heart rate, decrease relaxation. Increase in heart rate increases relaxation. Increase in heart rate decreases contraction, or increase in heart rate increases contraction. What is your more correct answer? What is most appropriate answer? Yes, doctor. Aditi and Infan are correct. Abhi is also correct. Sumant Gupta and Resham Singhal. Umesh. So these people are correct. So increase in the heart rate increases contraction. Okay. Let me explain this also. What is blood pressure? Blood pressure is equal to cardiac output into total peripheral resistance. This is equal to stroke volume into heart rate. Stroke volume depends on three factors. Stroke volume depends on three factors. One is preload, other is afterload, and third is contractility. Third is contractility. Okay, this is the basic formula which you should know. A lot of questions are based on this. Now before answering me the question, tell me, in athletes heart rate is less or more? In athletes heart rate is less or more? What do you think? Heart rate is less in athlete or more in athlete? Less. Why? Because stroke volume is more. They have larger stroke volume. Heart rate is less because stroke volume is okay. Resting bradycardia. Now in this you can see increase in heart rate increases contraction, because when there is increase in the heart rate there is an effect called as staircase phenomena. It is called as staircase phenomena. When there is increase in your heart rate, okay, when there is increase in the heart rate, okay, increased calcium will be released. Increased calcium will be released, and tell me, when there is increase in the heart rate, again try to imagine this diagram. If there is increase in the heart rate, and diastolic volume will become more or less. If there is increase in the heart rate, more blood will be coming here or less blood will be coming? If there is increase in the heart rate, try to understand, if there is increase in your heart rate, more blood will be coming or less blood will be coming? There will be effective contraction or ineffective contraction. There will be effective contraction or there will be ineffective contraction. Yes, ineffective. Yes, very good. So now you are getting the point. There will be ineffective contraction. So blood in your ventricle will be more or less. Blood in your ventricle will be more or less. Absolutely correct. There will be ineffective contraction. Very good. You all are having good concept. That's very good. Because if heart rate is more, yes, now you are absolutely correct. Abhi, when there is ineffective contraction, more amount of blood will remain in your ventricle. More amount of blood will remain in your ventricle. So what will happen to contractility? Contractility will increase or decrease. When there is more heart rate, there will be ineffective contraction. More amount of blood will remain in your ventricle, so that can increase your contractility because of stretch. Yes, so now everyone is correct, absolutely correct, very good. Yes, Suman Gupta, you are absolutely correct. So now everyone is answering correct, that increase in the heart rate increases contraction or contractility. So bathmotropic, lucitropic, inotropic, two more effects you have to remember. It has been asked in JIPMER, so it can come in your NEET PG, in your AIMS, in your next. So many examinations there are. Okay, so you should remember that increase in the heart rate increases contraction. I hope this point is clear to everyone. Now, all are related to. See, so many questions on the same. These all are questions from 1 year only. And see, a lot of questions are from cardiology. And that too, hemodynamics. All are related to negative lucitropy except. So, which is not correct about lucitropy? Negative. Which is incorrect for negative lucitropy? Yes, tell me. First of all, you should know what is lucitropy. Let me tell you, lucitropy is relaxation of the ventricle. Lucitropy is nothing new. It is relaxation of your ventricle. I am helping you out so that you can answer. Relaxation of your ventricle. Okay, now you should answer me correctly. Main point I have told you. Now tell me, what is excess calcium within the cell, defective calcium removal through an NCX exchanger. You should know what is NCX exchanger. Improper functioning of SERCA pump or excess catecholamine. What is your most correct answer? Yes, Rav Verma A, Sumant Gupta A, Tushar A, Aditi A, Abhi A. So everyone is answering. Hitesh Kumar A, okay. So almost everyone is answering A, but I should tell you it is not A. Answer is D. Let me tell you, answer is D. Excess catecholamine. I will explain, don't worry about that. Excess catecholamine. Yes, Akshay Gupta, you are right. Akshay Gupta, answer is D. So now let me explain, because almost everyone is incorrect in this question. No problem, this question was very tricky because they are asking negative lucitropy, not positive lucitropy. Catecholamine will cause positive lucitropy, isn't it? No, let me tell you. If you remember the T tubule, if you remember this diagram, very primitive diagram, you know, in your heart action potential is coming, plus calcium is also coming, and then there is mechanical coupling from ryanodine and DHP, and calcium is released, isn't it? Calcium is released, and this is helpful in causing contraction of your cardiac muscle. And this is your pump called as SERCA. It is an active pump, that is why relaxation is an active process. It is called as sarcoplasmic endoplasmic reticulum. Sarcoplasmic endoplasmic reticulum calcium ATPase, and it can be only done by phosphorylation of phospholamban protein. Have you heard about that? Phospholamban protein, it helps in relaxation. When phospholamban is phosphorylated, normally it is dephosphorylated. When it is phosphorylated, it causes phosphorylation of SERCA, and it causes influx of calcium inside. And this influx of calcium causes relaxation, and that is what called as lucitropic effect. That is what we called as lucitropic effect. Okay, this much is clear. Now coming to the question, excess calcium within the cell. Excess calcium within the cell are related to negative leukocyte. Yes, it is preventing your relaxation until calcium is put back by sarcoplasmic reticulum. It cannot relax. What is relaxation? What is relaxation? Influx of calcium inside the reticulum, not inside the cell. Influx of calcium back inside the sarcoplasmic reticulum is called as lucitropy or relaxation. So when excess calcium is within the cell, there is of course negative lucitropy. It is preventing the relaxation. Okay, because maximum are answering A, that is why I am explaining that. If excess calcium is within the cell, it is preventing the relaxation, not causing. Now second, defective calcium removal through NCX exchanger. What is NCX exchanger? If you remember, this is your sodium potassium channel and this is your NCX exchanger. It causes influx of sodium and outflux of calcium, isn't it? It is which type of transporter? Primary active, secondary active, or simple diffusion, facilitated diffusion, antiport or symport? This is example of which type of transporter? Tell me fast. This is example of which type of transporter? Yes, very good. Secondary active, and this is antiporter. Antiporter, isn't it? Yes, secondary, very good. So this is called as NCX, sodium calcium exchanger. You should know the name. Sometimes they will not give you sodium calcium antiporter, they will give you NCX. So if there is defective NCX, calcium will be inside. Calcium will be inside your heart. So can it cause relaxation? Yes or no? Can it cause relaxation? If calcium is not pumped outside, it is accumulated inside the, yes, so there will be no lucitropy or no relaxation of ventricle. There will be absolutely no lucitropy, or you can say there is no relaxation of the ventricle. Yes, increased contraction, and that is the property what digitalis is acquiring. What happened in digitalis? Digitalis prevent or block this pump. This property is captured by digitalis. Digitalis block this pump. If this pump is blocked, this will be automatically blocked because it is secondary active transporter. It is taking energy from sodium potassium pump. If you block sodium potassium pump, this will not be working and calcium will be accumulated. It will cause positive inotropic action. This will cause positive inotropic action. Am I clear? So positive inotropic action means there is increased force of contraction but negative lucitropic. So second option is clear, everyone. Defective calcium removal through NCX exchanger. This will cause negative lucitropy or this will cause positive lucitropy. So of course it will cause negative lucitropy. This option is again clear. It will help in creating negative lucitropic atmosphere. Okay. Improper functioning of Sarka. So this is the main pump which causes relaxation by phosphorylating which protein? Phospholambin. This is also one of the most important point. Phospholambin. Okay. So normally phospholambin is phosphorylated to cause influx of calcium by the Sarka, but if there is improper functioning of Sarka, it can be because of unphosphorylation of phospholambin, it can be because of clonus. There are so many reasons behind that. So all these will cause negative lucitropy, inability to relax. There is continuous contraction. Now, excess catecholamine, yes, they help in proper relaxation because relaxation is also an active process. So what they do? Catecholamine, they will cause phosphorylation of phospholambin and Sarka. So calcium will be influxed back inside and those will cause what? Positive lucitropy action. So this is the only only option which is having positive lucidity action, not negative. And questions were asking about the negative. So all were causing negative lucidity action. Only one is here which is causing positive lucidity action. Okay, now this we already discussed so many times, but let me ask you the question: what is the mechanism responsible for sustained vascular smooth muscle contraction? Quite easy question. So many times it has been discussed in Unacademy special class, in plus class. If you are already subscribed, or it is also discussed in YouTube classes also. You know this topic. Yes, very good, Dr. Akshay. It is latch bridge mechanism. What is latch bridge mechanism? Can you go in little bit detail of that? Okay, let me tell you how contraction of smooth muscle occur. Please revise this point again and again. Only revision can help you in sustained memory. Yes, so everyone is answering B, latch bridge. Very good. So, whenever there is phosphorylation of which protein cause contraction of smooth muscle? Who will tell me? Phosphorylation of which protein is going to cause contraction of smooth muscle? Calmodulin. Nah. Calmodulin actually combines with calcium combines with calmodulin. You are correct at this level. Calcium combined with calmodulin. You are absolutely correct here, because calcium binds with calmodulin, and this cause phosphorylation of which protein? Yes, Nisha Singh, Sai, Akshay Gupta, you are correct. It is MLCK. Myosin, please don't forget this one word. This one word help you in solving so many questions. Myosin light chain kinase. Myosin light chain kinase. Okay, so absolutely calmodulin is a necessary protein. You all are answering that. This is good. Calmodulin, whenever there is excess calcium, this calcium is going to combine with calmodulin, and calmodulin will exaggerate the process of phosphorylation of MLCK, and whenever there is MLCK phosphorylation, it can cause contraction. So it is not that complicated as in skeletal muscle. It is more complicated. There is sliding filament theory we have discussed. Now, which protein is causing relaxation? Which protein or which enzyme is causing relaxation? It is phosphatase enzyme. It is phosphatase. Phosphatase enzyme, yes, is causing unphosphorylation or dephosphorylation of MLCK. It causes dephosphorylation of MLCK. So if you remember one word, you can solve all those MCQ. MLCK, myosin light chain kinase. If it is phosphorylated, it is going to cause contraction of the smooth muscle. Okay, and when there is phosphatase enzyme, it will cause, when there is dephosphorylation of MLCK, it can cause two things. Either it can cause relaxation, or it can cause what else? What else can be caused? Either it can relax. Yes, very good, Nisha Singh. Sustained contraction. Very good. It can cause sustained contraction. Excellent concept. Very good. And this, yes, very good, Akshay. Sustained contraction, and this is called as which property of the smooth muscle? This is called as plasticity. This is called as plasticity. Your stomach, your uterus, your bladder, they are not elastic. Your lung is elastic. When you take air inside, it goes outside. But your stomach, bladder and all these are plastic. And this plastic is because of sustained contraction without use of ATP. Without utilizing your ATP. It is to conserve your ATP. And this mechanism is called as latch bridge. This mechanism is called as latch bridge mechanism. Okay. So this is the minimum which you have to remember. There's a lot of phenomena I will discuss in some other class, but this is the minimum to remember, that if MLCK is going to phosphorylate, there is going to contraction. Phosphatase enzyme can cause either relaxation or they can cause sustained contraction by latch bridge mechanism. So mechanism responsible for sustained vascular smooth muscle is latch bridge, or when they are asking about plasticity, even if they ask about plasticity, we can say the same answer, it is latch bridge mechanism. Okay, which of the following formula is the formula for compliance of chest wall? Yes, which of the following formula is the formula for compliance of chest wall? They are one step ahead. Normally you know about compliance, delta V by delta P, but they are going in one step more. There are two types of compliance. One is called as dynamic compliance. One is called as dynamic compliance. Other is called as static compliance. And both have different formula. This is going to ask in your respiratory medicine, your ICU medicine, ventilator. Sorry. Okay. What is your answer? So who is going to answer? Which of the formula is the formula for compliance of chest wall? Anyone want to answer this question? A. Okay, even you can guess the question. See, let me tell you, if you read the respiratory medicine, you know that you have to inspire. This is dynamic or static? If you are inspiring, this is dynamic or static, what I am doing. If you are asking the patient to do like this, it is dynamic or static? Tell me. Dynamic, of course, dynamic. So this is your peak pressure. When you are doing dynamic, this is your peak pressure, and this is your PEEP. What is PEEP? Positive and expiratory pressure. This topic is very important. It is positive and expiratory pressure. Remember these two values. So when you are asked about compliance of the dynamic delta V by delta P, you are taking, it is tidal volume, and this is the difference in the volume in the pressure change. So it will be peak pressure, minus PEEP pressure, minus PEEP. So you can see this is formula of static compliance or dynamic compliance. Tell me. This is formula for tidal volume upon peak pressure minus PEEP pressure. Is this dynamic compliance or is this static compliance? What do you think? You are doing, it is dynamic. Yes, dynamic compliance. So this will be formula for dynamic compliance. Very, very, very important question. Please remember that. Now let me, if you are asked to calculate the static compliance, you will do like this. You will hold your breath like this. This is your inspiration and this is your expiration. This is your expiration. This is a important, these are new topic, new high yielding topic, which can be asked in your examination. For the first time, JIPMER is going to ask that. So this is inspiration and you have to hold, you are holding your respiration. At this point, you are holding your breath. Patient is asked to hold the breath. So what is that called as? That is called as plateau pressure. That is called as plateau pressure. That is called as plateau pressure. So now you can calculate the formula also. You know compliance. It is of course not dynamic, it is static. It is static compliance of the lung, and compliance is VIP topic. So delta V by delta P, and V over here is tidal volume. V here is tidal volume, and pressure change will be of course, now it will become plateau, not peak, but now it is plateau. Pressure minus positive and expiratory pressure. So this is the formula for static compliance. This is very important topic. It is even not given in genome. It is given only in boron. If you want to read that topic in detail, or in, you can see nowadays respiratory medicine has become so important because of corona. So everyone want to know about the ventilation physiology and all those. So this is the base to understand all those graph and curve. If you know that this is your inspiration, this is your expiration, this is your dynamic, and this is your static. This is the basic graph. This is the basic graph. This is your peak. Okay. And this is your peep. This is your plateau phase. And this is your positive and expiratory phase. So difference between these two will cause calculation for, dynamic compliance. And if you minus plateau minus peep, it will help you in calculation of static compliance. So this formula is for static or dynamic. What do you think? P plateau minus P. Now they can ask you next question, which is the formula for dynamic, which is the formula for static. So no static formula is given here. So this is formula for dynamic compliance or static. Yes, very good. It is static. It is static compliance. Okay. So I hope this is clear to you. Any doubt, please ask me if there is any doubt, because this is a new topic. You need to understand this. I will try to take one whole lecture on this. ICU physiology, respiratory physiology, ventilation physiology, and all those graphs. But this is the basic which you have to remember, that what is peep, what is plateau, what is, this peak, and what is peep, and what is plateau. Okay, so everyone is clear? So that's nice, that's good. So thank you for today. Thanks a lot. And if you like this video, please like it, subscribe to Unacademy, and you at any doubt you can discuss it in my Telegram group. And if you like this video, please like it. Thanks. And subscribe to the channel so that you can get notifications. Thanks everyone. Thanks a lot.